Okay, welcome back, everyone. Looks like the participants are coming in to the webinar. We're very excited. This is day 4 of 5 for the Critical Care Boot Camp. Today we're talking about sepsis and septic shock. Want to again just thank all of you, the participants, for joining us. We have been absolutely inspired and overwhelmed by the amount of support coming from you. Some of the numbers have just been outstanding. We reached capacity yesterday with over 1,000 people joining the webinar, and over 4,000 people had registered for it. So we have expanded capacity today. So we should not reach the webinar capacity. Everybody should be able to join today. Additionally, we're just very inspired with the amount of representation from across the globe. We had a lot of people joining, obviously, from Rwanda and Kenya and the United States, but also from just about every other continent in the world. So we see you, Lesotho, we see you, Barbados, we see you, Myanmar, Venezuela. So we have a good representation from the Americas, Africa, and Asia. So thank you, Japan. Thank you, Thailand. Thank you, China. So very excited and inspired by all of the people from all over the globe working together to improve the care that we provide for critically ill patients. So again, excited. Thank you so much for joining us. We want to get started. So today, again, is sepsis and septic shock. A few housekeeping rules. Please keep this respectful. If you disagree with something, please do so with kindness. We want to be professional. Keep your comments on WhatsApp, in the chat, and in the question and answer relevant and professional. We will use the chat feature, so that's at the bottom of your screen. Please feel free to introduce yourself and say hello to others and where you're from. We'd love to see this community growing. However, please use the Q&A if you want to ask questions of the panelists. So comments and introductions in chat, but if you have a question about the presentation, please use the Q&A function. This session is being recorded. Your attendance is your consent to be recorded. Although participants will not be on video, your name may appear. So thank you for joining and agreeing to be recorded. Certificates. We're having a bit of certificate mania. Everybody wants their certificate. So we are doing our best. Again, we have hundreds of requests every day. Certificates will be given if you attend the session for 45 minutes or more. If you're on the session, you leave the session and come back. We do look at that. So it's the cumulative time you were on the session, 45 minutes or more, and a certificate will be sent to the name that you provided and the email address that you provided in registration. Please be patient. We have obviously thousands now of colleagues joining us, which we're very excited about. We're doing our best to get those certificates out to you on time. Again, all the slides, the webinar recordings, the resources that we provide are all available on our online school. It's called the LRC, or the Learning Resource Center. You can use this QR code that you see here, or you can use the link. We'll also provide the link in the chat. Again, if you want to see the slides, you want to download the slides, you want to see the slides with the notes and any resources such as bedside cognitive aids, algorithms, those will all be hosted on our Learning Resource Center. So please feel free to check that out. You do have to create an account, but we have pledged very early on that all of our materials for education will be free and open access, so there will never be a charge for these things. We recognize that there are people from all over the world, and English is not always the first language. Closed captioning is available in Zoom, so feel free to use that. You can find it at the bottom of your screen. However, our speakers today will be using English. We have encouraged them to speak slowly and clearly in consideration of our colleagues from around the world. We have a very active WhatsApp group since Monday. Please feel free to join us in that conversation. We are trying to share the resources, links, etc., in the WhatsApp chat as they become available. Again, please try to keep this relevant and professional and kind. Today, I'm very excited. Sepsis and septic shock are it's one of my favorite things to talk about, and I teach this often. Today, we have some very special guests. Dr. Frank Mutai is an anesthesiologist in Nairobi, Kenya. He has a very keen interest in critical care and in pain management. So welcome, Dr. Frank. Dr. Jacqueline Nakamura is an anesthesiology resident at Stanford University. Welcome, Dr. Jackie. Dr. Rachel Kimani is a consultant anesthesiologist at the University of Nairobi. She's also very experienced in global health. She just completed her master's in global surgery at King's College in London, and a good friend of mine, and we've done lots of this fun teaching together. I'm Dr. Anna Maria Crawford. I'm your host. I'm an anesthesiologist and intensivist at Stanford University. And also, I have a master's in global health sciences as well. So with that, we will get started with the webinar. So we'll get those slides up for you now.
Great. Thank you for the introduction, Dr. Crawford. So this is our presentation on sepsis and septic shock. I'm Dr. Jacqueline. I'm going to be talking with Dr. Frank. We'll be alternating speaking today. Okay, so this is just an introduction, a basic overview of what we will be talking about today. So sepsis is a critical illness that can have an insidious clinical onset. This may lead to misdiagnosis, poor prognosis, and subsequent worsening of clinical outcomes. This may also lead to poor short-term and long-term quality of life for patients. The treatment is multidisciplinary and challenging when management interacts with multiple different disciplines. This is a challenge in our daily practice for all practitioners around the country and the world, from all the places that you all are from. So just to organize our presentation, we'll be going through the definitions of sepsis and septic shock. We'll be talking about the epidemiology briefly and the pathophysiology of sepsis briefly. We will also go through the various diagnostic tools to identify early sepsis, as that is a critical time for management of sepsis. We will go through clinical features, lab values, and such that you can identify as a diagnosing sepsis. And then we will go through the management and a case study throughout these topics. This is a infographic that just shows really the basic overview of how to treat sepsis. We'll be going through more detail on certain topics, but this is to show that sepsis treatment is multifactorial. It takes a lot of different factors to go into treating a critically ill patient. Also to say that we will be focusing on certain topics in this infographic, like antibiotics, vasopressors, fluids. However, due to time constraints and focus of our presentation, we won't be going through everything on the slide, but this is a brief overview to show you how to treat sepsis when you are in the ICU or on the wards and needing a resource. Our slides are based primarily on the 2021 Surviving Sepsis Campaign International Guidelines. These guidelines were created in 2021, and they have been guiding management of sepsis for adult patients. However, there are two different guidelines that exist for two separate populations that are important to discuss. One is the pediatric population. They have their own criteria and campaign that was published in 2020, which you can find through the QR code. That's called the Surviving Sepsis Campaign International Guidelines for Management of Septic Shock and Sepsis Associated Organic Dysfunction in Children. And then this other one, or the other population of patients that should not be forgotten, is the OBGYN or peripartum patients who are undergoing labor or childbearing. And these patients have their own sepsis guidelines during pregnancy. Those were established in 2015. So we will be really focusing on the adult management. So we will not touch these pediatric and peripartum guidelines. However, these are for your reference if you need these for management.
So welcome everyone. To start with, we'll start with the definitions. So the definitions for sepsis and septic shock have not changed since 2016. And according to the Surviving Sepsis Campaign guidelines of the year 2021, sepsis should be defined as life-threatening organ dysfunction, which is caused by a dysregulated host response to infection. While septic shock, on the other hand, which is a severe form of sepsis, should be defined as a subset of sepsis in which particular profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with the sepsis alone. And in this group of patients with septic shock, they can be clinically identified by a vasopressor requirement to maintain a mean arterial pressure of 65 millimeters of mercury or greater, and a serum lactate levels of greater than 2 millimoles per liter in the absence of hypovolemia. So looking at the epidemiology of sepsis, sepsis is a major growing global burden and a challenge for almost every clinical provider. And the incidence has been continuously increasing over the years, as noted by in the Surviving Sepsis Campaign guidelines over the years. So in the year 2017, around 49 million cases of sepsis were reported worldwide, with around 11 million sepsis-related deaths, again worldwide. Sepsis bears a high risk of in-hospital mortality, accounting for approximately 20% of all cause deaths globally. Not only is it the number one cause of death in hospitals, but also number one cause for hospital readmission. And up to 50% of sepsis survivors suffer from different kinds of long-term effects, ranging from physical to psychological. And 40% of cases are common in children, especially the under 5s. So 80% of cases are in low and middle income countries. The largest burden is borne by the countries in sub-Saharan region, mostly countries in Africa. And the commonly affected populations in which again cuts across the world are children, especially the newborns with issues with neonatal sepsis, pregnant mothers, and the elderly. And however, it is good to note that there is limited accurate population incidence data from Africa on sepsis and septic shock.
This slide is to show the geographic implications of sepsis on populations. The darkest blue shows those most effective overall. So you can see dark blue in Africa, some of South Asia and South America. The top map shows age standardized sepsis incidence per 100,000 population for both sexes. And then the bottom slide, or the bottom picture, shows age standardized percentage of all deaths related to sepsis. This is an infographic from 2017, and it just highlights how those who are in lower socio-demographic index continents or countries such as Africa, South America, Southeast Asia are more affected by sepsis. And this goes among all ages, both sexes, and all underlying causes. About 52 million cases of sepsis were reported in 1990 and 41 million approximately in 2017. And these occurred in countries with low, middle, or middle sociodemographic index. It's a little hard to see the nuances of the colors in the map, but overall to show that this impacts countries in different ways. It affects us all, but in different magnitudes. And then the next slide, just briefly, is percentage of all sepsis-related deaths in each underlying cause by age group and both sexes. So what Dr. Frank was referring to, how children and elderly are affected by sepsis more than the middle age group population. This shows that the age groups at the very beginning and the very end of this graph show how those populations are more affected. And then this sort of separates out infectious causes versus injuries and non-communicable disease. And by and large, infection is the main cause of these sepsis-related deaths, which is one of the reasons why we're doing this webinar and why sepsis is so important, is that it can lead to mortality.
Jackie and Frank, if I might, thank you so much for including the last couple slides. The points you're making are great and I think very important when we see such high mortality from sepsis and septic shock, but we see that it affects patients in resource-constrained settings much more. There's not only the impact of morbidity and mortality, but oftentimes in these resource-constrained settings, the population is much younger, and that has also implications on the economics of not only the patient and their families, but also that entire community and setting. So thank you for pointing out the differences. We appreciate that.
So we've seen a lot of data. So this data led to the World Health Organization to declare sepsis as a global health priority. So why are we seeing this rising incidence? This alarming increase in incidence can be attributed to different factors. One is the advanced average age of among patients, especially in the Western countries. These are the patients who are vulnerable to sepsis with the immune system and immunocompromised states. Secondly, is the increase in number of invasive procedures, both in inpatient setup, emergency setup, and even critical care setups. Things like central venous cannulations, urinary catheters, and so on and so forth. Thirdly, we have the wide usage of immunosuppressive drugs and chemotherapy, especially in cases of oncology and patients with autoimmune conditions. Then finally, we've seen a lot of antibiotic resistance among most of our patients, which again cuts across the world, not only in the sub-Saharan Africa. So next we look at the pathophysiology, and from the definition we saw that sepsis is a dysregulated host response to infection, leading to a life-threatening organ dysfunction. So the normally careful inflammatory balance is disturbed, and this dysregulation is associated with a failure to return to the normalcy, the homeostasis. So what happens is that once a pathogen has succeeded to cross the mucosal barrier of the host, it can cause sepsis depending on its load and virulence. So the host defense system can recognize molecular components of the invading pathogen with the use of specialized receptors. So stimulation of these receptors has pro-inflammatory and immune suppressive consequences. It leads to activation of target genes coding for pro-inflammatory cytokines. There will also be inefficient use of the complement system, activation of coagulation system, and concurrent ion regulation of anticoagulants, which can further stimulate now the receptors. So immune suppression is characterized by massive death of cells, that is apoptosis, and thereby depletion of immune cells, reprogramming of monocytes and macrophages to a state of decreased capacity to release pro-inflammatory cytokines and a disturbed balance in cellular metabolic processes. So on looking at the pathophysiology of shock, we've seen that in the pathophysiology of sepsis, there is production of a lot of pro-inflammatory cytokines. So this will affect the endothelium by causing the loosening of endothelial cell tight junctions, what we call the glycocalaxy. So this leads to leaky vessels with increased permeability and leading to accumulation of protein-rich edema throughout the body. And with the effect of this will impede tissue perfusion. So with activated endothelial cells, they'll produce vasodilatory components, including nitric oxide and other vasoactive inflammatory mediators. This will cause vasomotor smooth muscle relaxation and systemic hypotension. So following vascular leakage and tissue edema, there will be decreased blood flow into the small vessels, and this will lead to stasis of circulation and diminished washout of activated coagulation factors. So basically, the coagulation factors will be sequestered on the small vessels, and which will lead to deposition of fibrin, rich thrombin in the small vessels, again worsening the perfusion. So it's another vicious circle. So with decreased tissue perfusion, it leads to hypoxia because there'll be minimal oxygen supply to the tissues, and therefore the cells will opt for anaerobic glycolysis, leading to production of pyruvic acid and lactic acid accumulation. This will be seen systematically as metabolic acidosis and electrolyte imbalance due to failure of sodium pump.
Thank you, Frank. For those pictures or slides were to demonstrate how complicated and complex the pathway of sepsis is and how we can see many clinical manifestations of sepsis in different ways. And not every patient is the same because everyone's body's working a little different, following the cascade in ways we are hitting and seeing patients at different timelines of the cascade as well. So we are presenting a case as a simplified version of what sepsis may present as. So this is not to reflect what all patients are like, and not to say that all patients could look like Mr. Goris. However, we'll talk about him today. So this is Mr. Goris. He's 66. He has a past medical history of high blood pressure. He's not on any medications. Unknown if he's been prescribed them, but he's not taking anything. He came in for 3 days with diffuse abdominal pain, blood-tinged diarrhea, nausea, and weakness. The facility that you are working at is a rural hospital in the country of your choosing. Vital signs are respiratory rate of 29, heart rate of 108, blood pressure 103/59. His temperature is 37.5 degrees Celsius. His SpO2 oxygen saturation is 91 on room air, but when placed on 3 liters nasal cannula of oxygen, comes 95%. So our question is, how would you screen for sepsis in Mr. Goris? So there are many ways to screen for sepsis, and early detection of sepsis is really critical to management of a patient, either in the ward, ICU, or in the emergency room, which is why so many diagnostic tools have been developed. There's a lot of discussion as well into the complexities of identifying sepsis. So these are not, this is an ongoing discussion, an ongoing topic of research. However, there are a couple tools that have been identified and are used in hospitals such as my own. The first is SIRS, or Systemic Inflammatory Response Syndrome. This is considered a clinical syndrome. It is a form of dysregulated inflammation, like we saw in our pathophysiology discussion. It was previously defined as 2 or more abnormalities in temperature, so above 38 degrees or below 36 degrees, a heart rate of 90 beats per minute or greater, a respiratory rate of more than 20, or PaCO2 of less than 32, so tachypnea. And then a white blood cell count of greater than 12,000, or leukopenia of less than 4,000, or 10% of immature bands. There are various conditions that can cause SIRS. And so there's infectious cause and non-infection causes, which makes this screening tool a little more difficult to use, and one of the downsides of it. So non-infection causes of SIRS can be associated with autoimmune dysfunction. They can also be related to vasculitis, thromboembolism, such as a pulmonary embolism or a DVT, burns, and surgery or postoperative care. So when you are suspecting a patient with sepsis, there has to be a correlating clinical exam and a SIRS criteria met. In this case, we met that criteria with his his heart rate and his respiratory rate. However, this is also based on the person who's screening the patient. So a respiratory rate, if the person isn't standing by the bedside and taking a good respiratory rate, or if the patient is not on monitors, or there are monitors that are missing, such as a temperature probe, these things can be affected, and the screening tool can be affected. So the next slide is another tool that is, I believe, primarily used in Europe, but this is a Muse or News score. They're basically the same thing. However, News is a more developed version of Muse. They're risk stratification scores, so they're a little more complicated than the SIRS criteria, which is one downside to this scoring system. However, it's more comprehensive than just 4 different tools in SIRS. So there's multiple categories. I'll focus on News because that's a more updated respiratory rate, oxygen saturation, supplemental O2 use for the patient, temperature, systolic blood pressure, heart rate, and loss of consciousness. Basically, similar to like the coma scale that we talked about, classical coma scale, you grading on a number, a numerical value based on what degree of the category they have. For instance, for loss of consciousness, the category, you would not get a point if you were normal mentation, but if you were demonstrating any sign of altered mentation, you would get a 3. And then using these scores, they sort of group you into 3 different categories: a low score, which is 1 through 4, a medium score, which is 5 through 6, or one of the red boxes, and then a high score, which is greater than or equal to 7. So for a low score, this would, by guidelines, it prompts a nurse or a registered nurse who can decide if should be a change to their clinical monitoring, or an escalation to an intermediate or intensive care unit is required for that patient. The medium score is should make a skilled clinician, whether that's a physician, physician assistant, nurse practitioner, whoever is available with competencies in acute illness and critical illness. It's going to also be a critical care nurse, or critical, some places have rapid response teams separate from the critical care team. So those individuals on that team can also identify if an escalation of care is warranted. And then a red score shows that this parameter is more sort of dire than other parameters. So the oxygen saturations on the very like on the category 3, which would represent less than 91 or greater or equal to 91, and those would be identified by these clinicians to escalate care. And then the highest rank should prompt emergency, so very quick evaluation and then transfer. The importance of this scoring system is really because delayed ICU admission or delayed assessment by a clinician is so prominent and a prominent problem in management of sepsis. And so this is to help triage patients and to allow patients to be admitted and cared for quicker rather than later.
Thank you, Dr. Jacqueline. This is an excellent point, and we have a few questions already about screening tools and scores. And I think you've outlined this very well. But there are several tools that you can use to screen for a patient that possibly has sepsis or septic shock. You mentioned the SIRS criteria. You've now mentioned Muse and NEWS, and I know you're going to talk about QSOFA in just a second. But I just want to remind the audience that these are all screening tools. This does not define sepsis or septic shock. It's important for the bedside provider, for all of us, to recognize a patient who is critically ill and possibly has sepsis and septic shock, because this is a life-threatening and time-critical condition. So thank you for outlining these tools and pointing out that these really are screening tools. It's up to us to use them and our clinical suspicion to diagnose sepsis and septic shock.
Thank you, Dr. Crawford. So the last screening tool that we'll discuss today is called QSOFA, which is also known as Quick Sepsis-Related Organ Failure Assessment. There's been a lot of discussion about using this criteria for screening for sepsis, and different guidelines have changed. Most recently in 2021, the critical care guidelines that I had mentioned in the beginning of this talk, which we are using for this presentation, said that QSOFA should not be used as a single screening tool. That is not the case for SIRS and NEWS or Muse, but QSOFA only has 3 components to it: respiratory rate, systolic blood pressure, and altered mentation. And this can reflect mortality. However, it has been shown not to be a good screening tool for sepsis, even if there is a positive sign. So if there is a positive sign, if your institution does use QSOFA, it should alert you to the possibility of sepsis, but it has poor sensitivity. And the guidelines show that we should not be using it only to screen patients for sepsis. It was originally validated in 2016 for patients suspected at having sepsis, but those not in the ICU. And there's been subsequent research on QSOFA for different populations. However, the consensus is that we should not be using this as our sole diagnostic tool. And then just to sum up of the different diagnostic criteria, this is just a picture of how they differ from each other. And you can see that QSOFA actually lacks a lot of the parameters that both SIRS has and Muse and NEWS have, and Muse and NEWS are really the most comprehensive that we have. Like I said earlier, the amount of time that one clinician has or the ability to screen for these things are operator dependent. If they're a nurse taking care of multiple patients on the ward, how much time does she or he have to screen the patient is, depending on the resources of the hospital and the skill level of the clinician. But all to say that screening for sepsis is an important part of management for sepsis and should not be delayed. And these are the tools that you can use at your institution to screen for those patients.
So on to our case, Mr. Corris is admitted to the ICU due to concern for sepsis. So this for adults with sepsis or septic shock who require ICU admission, the patient should be admitted within 6 hours into the critical care unit. So on to our poll question, which lab is critical for management when septic shock is suspected?
So everyone should be able to see the poll question now. We're going to give you a minute and a half to answer the poll question. So please submit your choices. Okay, the poll has closed, and here are the results. So it seems like we have a little bit of a spread. Some people are saying leukocyte count, others are saying lactic acid or lactate. So we'll let our presenters talk a little bit more about that, maybe on the next slide.
Great, thank you for answering the question. It's a bit of a tricky question, and we recognize that the point of the question was to show these guidelines from Surviving Sepsis campaign, which shows how to triage your care, basically prioritize different things, caring for a patient who you've identified with the different criteria we talked about as a patient with sepsis or septic shock. And the guidelines recommend that you measure a lactate level as the first lab value, or the lab value if you had one lab value to look at. However, of course, in our facilities, it's easily, or certain facilities, it's easy to just get a bunch of labs, a rainbow labs of CBC, CMP, coags, all the different things that you could possibly get on a patient when you're drawing original blood. But if you had one test tube or one lab to send down, it would be lactate level based on the Surviving Sepsis campaign. Lactic acid is a marker of perfusion. This is also a topic that's highly debated in critical care literature. Lactic acid can be two different types, categorized as type A, which is due to impaired tissue oxygenation. that can happen from hyperperfusion. So what we discussed for the pathophysiology, the tissues are not getting enough oxygen when a patient is in shock. That can be related to sepsis, but it can also be related to other types of shock, including hypovolemia, cardiac failure, cardiopulmonary arrest. In this sepsis campaign, they're showing that lactic acid is important for identifying sepsis, or one of the various tools that you can use to identify sepsis. Type B is a less common, but it is important to know that there is another type of lactic acid or elevation that can happen, and they kind of sort of allude to this when they say in their guidelines, but basically these patients don't have hyperperfusion in their clinical exam that can be caused by toxins, tissue ischemia in a certain part of the body, high levels of metformin or epinephrine, malignancy, alcoholism, drug-induced mitochondrial dysfunction, which can happen in HIV patients. Liver dysfunction is another cause of type B lactic acidosis. So all this to say is that lactic acidosis or lactic acid, when you have an elevated lactic acid, there are many things that it can be. One thing it can be is sepsis, and with clinical exam, you can use that information to guide your management. The other part of obtaining lab work, which was not mentioned in the poll question, but is very important in the beginning of sepsis, is obtaining blood cultures, and specifically before antibiotics are given, because giving antibiotics can interfere with your blood culture results. So as I discussed earlier, the clinical features of sepsis is varies per patient. Among patients of the same demographic, age group, gender, clinical features can be very different, and also relate to the timing of when you're meeting this patient. If it's either early, this patient has just arrived to the emergency room, just developed the infection, or the patient has been sitting at home with an infection brewing, and there are late signs of sepsis. This picture is a good reference for you using in the hospital if you need to identify a patient with sepsis but not really sure where to start. There are lab works like we talked about that are important to obtain that can help you understand if this patient's painting a septic-like picture, such as elevated CRP, elevated procal, but those are not meant to diagnose sepsis. They're showing elevation in inflammation in a patient's body. Late stage of septic shock would be renal failure, shocked liver, DIC, or disseminated intravascular coagulation or coagulopathy. The focal exam findings or related to your vital signs could be tachypnea, elevated heart rate, tachycardia, or decrease in your blood pressure. And then this also shows a difference between warm shock versus cold shock. Warm shock presents earlier in the clinical picture overall, and cold shock presents later. Cold shock can also be mixed up with cardiogenic shock, which can be present in the same way. So the clinical picture has to be taken together with the history, the screening for sepsis, and then what you see on both lab work and physical exam. So the next slide will show related to the physical exam. This is important for you as the clinician to identify if there's a source of sepsis that can be intervened on easily. So not just throwing antibiotics and missing what's in front of you, but that the cause can be related to what you've been doing to the patient. For in its instance, a patient that's been in the ICU for a long time and has had a central line or some JP drain, or had a post-surgical patient with an incision that looks strange. These are important to assess every day by the bedside provider to make sure there is not a sign of infection, tenderness, redness on exam. Other things that can be helpful on physical would be using an ultrasound machine. Everyone's capacity to have an ultrasound machine, ability to have an ultrasound machine is dependent on the facility that you're in. So we recognize that not everyone can use an ultrasound. But endocarditis would be a cause of sepsis, and that can be seen with echocardiogram. Of course, that would be operator dependent if they can identify a vegetation. Lung ultrasound is also useful if for whatever reason X-ray is not available to maybe identify pleural effusion or a pocket that can be potentially drained with thoracentesis or pigtail catheter. Like our case, Mr. Goris, he had a tender abdomen, but he was not rebound or guarding. If a patient has an acute abdomen, that can suggest appendicitis or pancreatitis, cholecystitis, that is a surgical intervention. And then all extremities should be well cared for and examined by a clinical provider, especially the bedside nurse, which helps us a lot in our ICU for soft tissue infections, sacral ulcers that could become infectious. Even if a patient comes in without a soft tissue infection, can easily develop from being in the hospital for a long period of time. So all this to say is that you want to identify if there is a source of sepsis that can be removed or surgically intervened on earlier rather than later.
So back to our case, Mr. Goris, a physical exam was done and neuro exam. He was awake, alert, with no focal findings. On the cardiac exam, there was a regular heart rhythm, but at a faster rate. The pulmonary system showed was clear to auscultation. The abdomen was soft and tender in the lower quadrants with no rebound or guarding. On the extremities were, however, cool. Capillary refill time was 3 seconds with no edema. On the labs came back. The lactate was 4.5 millimoles per liter, WBCs of 17, with serum creatinine of 230 micromoles per liter. On the vital signs were repeated. He had a respiratory rate of 28, heart rate of 115 beats per minute, blood pressure of 99 over diastolic of 42 millimeters of mercury, temperature of 38.5, and saturations of oxygen of 94%, and he was on 3 liters oxygen 3 liters per minute. So back to our poll question, what will be your next step to prioritize in management?
Okay, participants, you have 1 minute and 30 seconds to select your choice for the question. What would be your next most immediate step to prioritize in the management of Mr. Goris? Okay, the poll is now closed. So again, we have an interesting spread. Some people want to start vasopressors right away, and some people want to do antibiotics right away, and some people want to do diagnostics right away. The answer is really all of them are going to need to be done quickly, but our speakers will tell us which one is the most immediate next step.
So this slide shows a summary approach to basically a patient like Goris. Of note is that sepsis is a medical emergency and treatment and resuscitation should start immediately. Among the resuscitative tasks that you should do is to initiate empirical antimicrobials, start fluids, vasopressors, and other supportive measures like nutrition, and others that we'll look in the subsequent slides. So we are going to look at each resuscitation measure individually. So the first pillar of sepsis and septic shock is administration of antimicrobial. So it is the first pillar of sepsis and septic shock treatment, and the administration of a prompt empiric antimicrobial therapy at the time of sepsis, identification, and after the collection of appropriate culture is a crucial step in pharmacological management. So microbiological samples should be assessed as soon as possible on admission, which can include what we've just seen, can either be blood and fluid or tissues from other sites deemed proper based on the clinical evaluation. And the choice of empiric antimicrobial therapy is based on the clinical the clinical assessment and the epidemiological criteria for the patient. And antimicrobial treatment should be reevaluated daily with the aim of a correct de-escalation as soon as the results of the culture are back or are available.
Dr. Frank, if I can stop here for just a minute, because there are often many questions about starting antibiotics versus sending diagnostics such as blood cultures, urine cultures, and respiratory cultures to identify the source of sepsis. We need to remember that sepsis and septic shock are caused by that dysregulated host response to an infection. So we know that we're looking for infection and we need to get source control quickly. However, I want to caution the attendees when you're treating someone who is in this life-threatening, time-critical condition, we need to start antibiotics as soon as possible. If we can get the blood cultures, urine cultures, respiratory cultures sent quickly and at the same time, that is ideal. We do not want to withhold antibiotics in order to get those specimens sent to the lab. So the priority is the patient. The priority is treating the infection. So if for some reason there is a delay in sending blood cultures and other specimens, please remember to treat the patient. That's why we're all here together, is to help patients. So I just want to point that out, that antimicrobials are very important to be given early. Thank you.
So we have this debate about the 1 hour versus 3 hour bundle, and different studies proposal are there on comparison between the 1 hour and the 3 hour bundles. But from the current guidelines, it proposes that the administration of antimicrobials should be immediate, ideally within 1 hour, in patients whom sepsis is highly suspected, that is with or without shock, or when sepsis is possible and shock is detectable. So that is within the first hour of contact with the patient. For the 3 hour bundle, in case there is a low to moderate risk of sepsis without signs of shock, the administration of antimicrobials is recommended within the 3 hours if concern for infection persists, and after performing an assessment of infectious versus infectious causes. So this is after the time you've taken samples for cultures. Our second pillar is intravenous fluids. So generally, sepsis is accompanied by severe vasoplegia, which is secondary to the shedding of the glycocalaxy, the effect on the endothelium by the pro-inflammatory cytokines that we saw in the pathophysiology. So an affliction that may lead to distributive shock. So the effective support of hemodynamic function is essential for the survival of these patients with sepsis. Types of fluids, which there's the debate about which fluids are better than the other ones. So we have crystalloids and colloids. Crystalloids, we have two types. We have the chloride-rich solutions and the balanced crystalloids. The administration of balanced crystalloids is preferable over the normal saline for majorly two reasons. One is that they have an electrolyte composition which is closer to the plasma. And secondly, the chloride-rich solutions are associated with high risk of hypochloremic acidosis, especially if you administer them in large volumes in rush of trying to resuscitate the patient. So the best fluid between the two colloids and crystalloids are the crystalloids. Between the chloride-rich solutions and the balanced crystalloids, the guidelines recommend the balanced crystalloids. For the colloids, we've seen from the pathophysiology that the integrity of the endothelium, that is, you lose the glycocalaxy. So actual intravascular volume of these fluids, especially if you're administering colloids, is apparently less than expected. And there is no data which demonstrated the superiority of colloids over crystalloids. We all know that crystalloids are associated with adverse reactions, and they are also expensive and not available in most of the setups. It also increases risk of tubular necrosis and acute kidney injury after treatment. But for albumin, it is recommended as it has a theoretical advantage over crystalloids in maintaining the oncotic pressure and so improving the hypovolemia. How much is enough? The Surviving Sepsis campaign suggests at least 30 mL per kg of crystalloids within the first 3 hours. And one should perform an individualized treatment targeted towards now what we saw, the glycocalaxy resuscitation, according to fluid tolerance and fluid responsiveness. Basically, fluid tolerance can be expressed as the degree to which a patient can tolerate the administration of fluids without the onset of organ dysfunction. For fluid responsiveness, it's commonly defined as the stroke volume increase of at least 10% following fluid bolus of 200 to 500 mL in around 10 to 15 minutes. The fluid tolerance can be expressed as the degree to which a patient can tolerate the administration of fluid, which we said. So since it's actually impractical to standardize the amount of fluid according to each patient, an individualized strategy of resuscitation based on the fluid tolerance and fluid responsiveness is preferable.
Dr. Frank, I'd like to stop for a second here as well, because I know there are going to be many questions about the types of fluids and the amount to give. So if I can interject for just a moment. Historically, we have used crystalloid fluids to resuscitate patients, and often that was either normal saline or another balanced salt solution, such as Ringer's lactate or lactated Ringer's. The most recent surviving sepsis guidelines, the one from 2021, are saying that Ringer's lactate or another balanced salt solution should be used over normal saline. Another balanced salt solution could be something like Normasol or Plasmolite. Those are available in our setting. And the reason we don't want to use the normal saline as a first choice is because it can lead to a hyperchloremic metabolic acidosis. There's also a correlation with increased renal dysfunction. So that's about the type of crystalloid that we can use. Regarding the amount of fluid to be used, we want to make sure that we are giving the patient enough fluid to resuscitate them, to optimize hemodynamics, to optimize mean arterial pressure, but we don't want to give too much fluid. There's not one easy answer to how much fluid should be given. It depends on the patient. It's up to the bedside provider to continuously reevaluate the patient to determine if that patient is volume responsive or not. So we do know that there has been historic recommendation to give at least 30 milliliters per kilogram of IV fluids in the first 3 hours. You want to ensure that you have given your patient enough fluid prior to starting vasoactive infusions. But there's not an easy answer. There have been some studies in multiple settings across the globe, specifically in pediatric patients, where large volume resuscitation led to increased mortality. We need to be very careful that we give fluids to each patient on an individual assessment. Some of the possible reasons why the children did worse with the volume resuscitation is that study was done in African children who had malaria. So there was some concern that maybe the children were actually more anemic, and giving large volumes of crystalloid led to that increased mortality. Similarly, there's evidence that giving large volumes of fluid to adult patients in resource-constrained settings in Africa also led to a higher mortality. Some of the explanations were that perhaps they got so much fluid that they became they had a pulmonary edema and a respiratory distress, and because we don't have the ICU capacity or capability in all settings, that perhaps it led to respiratory distress that was unable to be supported. However, other studies have taken the respiratory pulmonary edema patients out and still noticed an increase in mortality. All of that is not to discourage the use of intravenous fluids. Intravenous fluids are a core component of resuscitation in septic shock. The takeaway point is that we must continuously reassess each individual patient to determine the amount of fluid that is needed to resuscitate that patient. So we'll talk a little bit more about how to determine if the patient is fluid responsive or not in the next few slides, but I want to caution people that there's no one answer about the amount of fluid. Does that make sense? Is that helpful? Yeah, okay.
Thank you, Dr. Crawford. So to continue on the discussion of how you decide whether or not a patient has received enough fluid or too little or too much fluid, there are various markers. And like Dr. Crawford saying, to take them all together and using the patient's clinical history and picture to understand if the patient is being perfused or resuscitated. So we've listed out a few, but there are more. Central venous pressure, pulse pressure variation, trending lactate levels, POCUS or point of care ultrasound, passive leg raise, capillary refill. All these are dependent on the capacity of the institution and then the skill level of the provider. So just to go a little bit by each one, central venous pressure was developed in the 90s, and it was a way to monitor a patient's intravascular volume status through a central line. However, this practice has been questioned because it requires a central line, which can lead to all the complications of having a central line, including infection, bleeding risk or damage to the nearby organs. So that is fallen less out of favor, or is not in favor, compared to other markers, such as pulse pressure variation. Pulse pressure variation is the difference between systolic and diastolic arterial blood pressure that varies with respiration. There are many infographics online that you can look up about how to identify pulse pressure variation on an arterial waveform, which kind of looks like a divots in the peaks of the blood pressure markings. However, this is limited by patients who are on mechanical ventilation only. So it is only been studied in patients with on tidal volumes of more than 8 cc's per kilo. And it also patient has to have a regular rhythm. So those patients in AFib or AFib with RVR, not really applicable to those patients. And patients who are triggering the ventilator on their own, it's also not applicable to them. Like I discussed earlier for lactate levels, these can be trended, and in our guidelines, there is evidence to suggest that providers should be trending lactate levels, and that can be an area of showing that the patient is resuscitated, but it is highly debated of whether or not trending a lactate level on its own is a way to only show, or only to understand if the patient has been resuscitated or not. And capillary refill and lactate levels have been studied against each other, and actually this one study showed that capillary refill was more accurate in assessing if a patient was adequately resuscitated. And a capillary refill is bedside dependent and provider dependent, but a normal cap refill would be 3 seconds or less, and then a delayed capillary refill, which would show slower perfusion to the extremities, would be longer than 3 seconds. Then to go on for passive leg raise, this is a very easy way to show and doesn't require, or show if a patient is volume responsive or not. It also doesn't take much equipment and much skill level to do so. And this is the only way to do it is doing it accurately, which can be instructions can be looked up online if you forget. But basically, you are providing a patient with a bolus with their own blood from their lower extremities, and you have to position the patient so that their head is down and that their torso is in a flat position, and then you put their leg to 45 degrees, and you see if the cardiac output goes up. Of course, that would require a pulmonary artery catheter or some way to measure the cardiac output. So a lot of bedside evaluation looks at really if the blood pressure changes, if it goes up or down, and there's not specific ways to, or not studied ways to see how much the blood pressure should go up, or that would warrant that the patient is positive straight leg raise test. So it is sort of operator dependent, making sure that this is done properly, and it is taken in the overall clinical picture. The last is the ever growing importance of the echocardiogram, or POCUS, that looks at the IVC. IVC diameters can be measured by the operator, and a change in IVC diameter by 12 to 18% is associated with fluid responsiveness. And that has been shown in mechanically ventilated patients, but is also used in non-mechanically ventilated patients.
Dr. Jacqueline, that was excellent. Thank you so much for that review. This is a source of concern and confusion for so many of us when we're treating patients with sepsis and septic shock to determine if they're fluid responsive, do they need more fluid or not? I just want to contextualize this for a more global audience. When you're looking at pulse pressure variation, you need an arterial line. So if you don't have arterial lines available to you, then you're going to have to use some of these other mechanisms. Similarly, the central venous pressure requires an internal jugular or subclavian line with a pressure transducer, which may or may not be available in all locations. There's another way to monitor cardiac output and fluid responsiveness called stroke volume variation. That actually requires a completely separate monitoring type system. So some of these things are not available in all locations. However, capillary refill and passive leg raise are available anytime there's a patient. So you can always look at your patient to determine if they are fluid responsive. Look at the capillary refill and see if it's less than 2 seconds. Try to do the passive leg raise if it's not contraindicated, and see if the blood pressure goes up. Those are the most inexpensive and accessible ways to determine if the patient will have an increase in their blood pressure with additional volume. If you have timely access to lactate and are able to trend that, then certainly try to do that. That's one of the recommendations from the recent guidelines. Point of care ultrasound, or POCUS, is increasing everywhere. More and more people are using ultrasound. It's inexpensive, it's non-invasive, it's painless. It's a very good way to look at your patient. I do want to caution, however, that with central venous pressure and the inferior vena cava, both of those are indicators of whether or not you have fluid in the venous system that's coming back to the heart. However, both of those things can be affected by positive pressure ventilation. So if the patient is on mechanical ventilation, that can affect the pressure reading in the vena cava. So we have to use this in consideration of the overall picture of the patient. So I completely agree with Dr. Jacqueline's point that these things are great at giving us information, but it's really the overall picture that we must consider when resuscitating patients. So thank you. Hopefully it's okay I interjected again.
Like we talked about earlier, for patients who are hypotensive, those patients should, in septic shock, those patients should be started on a vasoactive agent. The main takeaway from this slide is that we should be targeting MAPs of 65 or greater. Of course, different patient populations may not be the right target for this MAP. However, this is sort of like a guideline for all patients that in order to perfuse all the different organs in their body, we should be targeting a MAP of 65. What type of vasopressor is discussed and debated among critical care providers for septic shock? The guidelines suggest that norepinephrine is the first line vasopressor to use for patients in septic shock. If norepinephrine is not available, epinephrine is an alternative. However, there's an arrhythmia risk. So norepinephrine would be our first line of choice. When the pressure requirement is going up beyond 0.25 micrograms per kilo per minute to 0.5 micrograms per kilo per minute, and the MAP goal is unachieved, then recommendations that we add on vasopressin. Vasopressin would be our second line. It is not as titratable as Levophed or norepinephrine. And so if that is not helping with the blood pressure, then we would consider adding on epinephrine if vasopressin and norepinephrine is not sufficient. There are many ways to think about vasopressors and many different patient populations that can be tailored so that we give the right agent for them. And one specific population is those in cardiogenic shock or mixed septic cardiogenic shock, patients with low ejection fraction, and or cardiac dysfunction within the setting of sepsis. And it is recommended that patients are started on either dobutamine to help with forward flow or switching to epinephrine. Both have downsides. Of course, dobutamine can cause more dilation in vessel capacitance, and so it can lead to lower blood pressure, but would help with contractility for patients with low contractility. And then epinephrine can cause arrhythmias, high tachycardia, and so adding it is not come with it comes with side effects that can affect the patient in different ways. So this is a sort of overview. Of course, there are many ways to think about this, but the guidelines do suggest that norepinephrine is the first line agent.
So we look at some of the supportive management other than the three pillars that we've seen. And one of them is prophylaxis for VTE. So since critically ill patients are at risk for deep venous thrombosis and pulmonary embolism, heparin should be included in the treatment of these cases. So we saw from the pathophysiology that sepsis and septic shock can induce disseminated intravascular coagulation, which is again a life-threatening complication that can lead to multiple organ failure. Heparin can also, in addition to being used to prophylaxis for DVT and pulmonary embolism, it has anti-inflammatory effects. It also has anti-complemental activation and modulation of various proteases. It is thought to also mitigate pulmonary hypertension by interrupting neutrophil adhesions to the lung endothelium, and this reduces neutrophil migration into the interstitial space, which ultimately leads to decreased edema. So it plays many roles, and it is important again as a supportive measure for in sepsis and septic shock. So the other complication of sepsis is causing stress hyperglycemia, which is due to increased glucocorticoid and catecholamine release and insulin resistance. So, and this stress hyperglycemia can worsen septic patients' outcomes. So it is recommended that adults with sepsis and septic shock to be initiated insulin therapy at glucose levels of more than 180 milligrams per deciliter. That's around 10 millimoles per liter. So for adults with sepsis or septic shock who are with sepsis or septic shock who are at high risk of peptic ulcers, especially with shock and prolonged ICU stay, and are likely on steroid use, the current guidelines recommend that they should be started on stress ulcer prophylaxis. You can use a PPI or an histamine antagonist, H2 inhibitor. And since the stress ulcer prophylaxis is inexpensive and it requires limited resources and is abundantly applicable even in low resource setups.
Dr. Frank, we had talked a little bit about stress ulcer prophylaxis, and for a while there was a bit of a debate on whether or not to use proton pump inhibitors or H2 blockers. There have been some arguments that proton pump inhibitors might cause increased pneumonia, increased C. difficile infections. However, those studies that were done did not do an adequate job of accounting for confounders to the outcomes. Patients who have sepsis and septic shock in the intensive care unit have several risk factors for stress ulcers, one being septic and in shock, two being on vasopressors, three if they're in PO and not eating. Additionally, many are on mechanical ventilation. Additionally, many are in the intensive care unit for more than just a couple days. So several risk factors for stress ulcers. So we recommend using stress ulcer prophylaxis. If you have a proton pump inhibitor, if you have a histamine 2 blocker, either one is adequate for prophylactic use while the patient is in critical condition.
Thank you. So the other supportive measure is renal replacement therapy, and acute kidney injury is a common complication, affecting about 40% and up to 64% of septic and septic shock patients, and thus mortality rates increases. So the techniques that can be employed in renal replacement therapy include continuous RRT and intermittent hemodialysis. And RRT is commonly required in these patients which are associated with other absolute indication for dialysis, like patients with severe metabolic acidosis, refractory fluid overload, or those with electrolyte imbalances and uremic complications. The other supportive measure is the use of steroids. Since sepsis induces a pro-inflammatory state and cytokine cascade, they are thought to contribute significantly to the manifestation of the disease. So various studies have proposed the use of steroid treatment, and especially the use of steroids. And more specifically, it has been suggested by the Surviving Sepsis campaign for adult septic patients not reaching the target maps despite vasopressor administration. On sodium bicarbonate, most experts believe that this treatment is appropriate in cases of severe lactic acidosis and acidemia, that's pH of less than 7.1, which may lead to hemodynamic instability as a result of reduced left ventricular contractility, atrial vasodilation, and impaired responsiveness to catecholamines. Next. I think I've talked about the sodium bicarbonate therapy.
So just to summarize, sepsis is extremely important. It leads to mortality in all of our hospitals across the country and the world. And why is it important that we're doing this webinar? Why do people want to learn about sepsis? There's been actually a study by Centers of Medicare and Medicaid, which is a US entity in 2015 that looked at national quality measures for patients with severe sepsis or septic shock. And it showed that providers were not compliant with a lot of the guidelines that, this was before the 2021 guidelines, but guidelines that were issued at that time when they did the study. This showed that for patients with severe sepsis, providers were not administering intravenous fluids adequately, repeating lactate levels adequately, documenting volume and tissue perfusion assessments, not administering vasopressors in a timely manner, and not administering broad spectrum antibiotics. The point of our poll questions was to show how, things can be missed because things have to move quickly, and there are multiple ways that patients need to be managed. For patients who are receiving inadequate care that can lead to poor patient outcomes, and also inconsistent patient management within the hospital, being cared for by different providers, between hospitals, between states and countries, and all around the world. And so the point of these international guidelines were to make sure that we're treating septic patients equally and equitably. And the last is that patients don't understand what sepsis is, or when an infection can be turning into a worse infection than they expect. And so learning about sepsis is important not only for the clinician, but the non-clinician, to understand how infection can lead to bad outcomes, and how to identify an infection in their loved one. So key points, like I had mentioned, it's life-threatening, can be caused by dysregulated host response to an infection. We talked about the definitions of shock versus septic shock versus sepsis, but this leads to mortality. It disproportionately affects low, middle income countries and those in the lower and higher stratum of age groups. So basically, those who are most vulnerable are affected by sepsis, which is why it is so important that we learn and discuss septic management. There are various pathways that lead to sepsis within our bodies, and they vary by patient. We can quickly diagnose patients with sepsis by these criteria that I discussed, such as SIRS, NEWS, MUS. But the main point is that we should be watching for sepsis among our patient population. Management is multifactorial, like Dr. Frank had talked about. It not only just includes antibiotics and fluids and vasopressors, but includes DVT prophylaxis, GI prophylaxis, and acid-base management. This is to point out again our next slide, which is the summary I had mentioned in the beginning, which can be used for any patient who you think sepsis may be life-threatening or you may be suspicious for. And we discussed some of these topics, but we did not discuss enteral feeding. We didn't discuss lung protective ventilation, which are extremely important for patients who have pneumonia, ARDS, or prolonged ICU hospitalization. And so this can be, looked into by yourself or other talks online. And then our references were based on the Surviving Sepsis campaign, like I discussed in 2021. So our guidelines come from this. And with that, that's the end of our webinar. Thank you for listening from around the world. We really appreciate you learning from us.
Wonderful. Thank you so much to Dr. Jacqueline and Dr. Frank. We have a few minutes, 1 minute. So I want to address some of the questions that have come up in the Q&A box. Just to note that we've answered over 90 questions, so lots and lots of good questions. One question was about urine output, and should that be used as a measure of adequate resuscitation? In general, yes, we definitely want to keep an eye on urine output through a urinary catheter. However, as Dr. Frank mentioned, acute kidney injury and acute renal failure are very common in distributive shock seen with sepsis. So because the kidneys can have that same dysregulated response and have impairment, it's not always the most timely monitor for resuscitation. So we would look at the other things such as passive leg raise. We would look at capillary refill. If you have access to point of care ultrasound, you can use that as well. Another question we have is about vitamin C. A few years ago, lots of people were looking into vitamin C to see if it can help improve outcomes in sepsis and septic shock. The current recommendations state that vitamin C has no role in treatment of sepsis and septic shock. So we do not use vitamin C currently. Some other questions have come up around using blood transfusion. Blood transfusion does not have a role in sepsis and septic shock. It is not used as a resuscitative fluid. Blood transfusion is used for anemia. So if your patient has a significant anemia, then you would consider a blood transfusion. This has been looked at extensively in critical care literature. And if the patient has a hemoglobin of less than 7, then you would use blood transfusion. However, if the hemoglobin is above 7, it's not recommended that we do a more liberal transfusion approach. So we have lots of other questions. Unfortunately, we're not going to be able to get to all of them in the time of the webinar, but please be reassured that we will look at all of the questions and create for you a frequently asked questions document. This webinar recording, the slides from Dr. Jacqueline and Dr. Frank, a resource library with all of those great algorithms and guidelines that we shared, and the frequently asked question document will all be hosted on the Learning Resource Center. I'll put that in the chat one last time. You can go there, you can download all of these things. Everything is free and open access there. Again, we are so grateful to all of you for joining us. We'll see you tomorrow for the 5th webinar in the Critical Care Bootcamp series. And we look forward to seeing you there. So thank you so much.